questions. You mentioned high flow nasal cannula and high flow oxygen options. Dr. Hurst, can you discuss a little more about what these entail?
Yeah, so there's a few that people will be familiar with. Obviously, we have our standard nasal cannula and Veni mask and non-rebreather, which almost seem like a joke in the setting of COVID these days, because despite the fact that they tout being able to deliver, a rate of an FiO2 of 45% or 60%, our patient really benefits from probably even the small amount of PEEP that is provided with some of these higher flow oxygen devices, and really require the flow in order to maintain that oxygenation. The two devices that are used most commonly at our institution are the Salter nasal cannula, which is just, I mean, if you saw it at bedside next to a regular nasal cannula, you may not notice a significant difference. But when you get up to the bedside and actually palpate the two different types of tubing, you'll identify that Salter nasal cannula actually has much stiffer tubing, allowing for a higher flow. And then if you look closely at the nose, the piece that moves along the nasal bridge or is anterior to the nasal bridge, you'll see that there's a little bit more space in that area of the nasal cannula, and that allows some higher flow rate, as well as you have oxygen that has a small reservoir in that tubing. That's probably our first step for the majority of our patients that are struggling with hypoxia in the setting of COVID. And the utility of that is it allows them to be a little bit more independent than something like a Veni mask or a non-rebreather, where their nose and mouth aren't covered, but they're able to eat and drink and have a little more freedom to do some of those things that we talked about in retaining normal life skills like FaceTiming and communicating easily. And then for our patients that are struggling with more significant hypoxia, we often move up to devices like OptiFlow, which can deliver up to 100% FiO2 and 60 liters of flow. And if you actually look in the literature, it's hard to know, are our patients truly getting 100% FiO2? They're probably in training some degree of room air, and so that FiO2 may be a little bit lower. Their lungs may be seeing a little less than truly 100% FiO2. It could be more close to 80 or 90% FiO2, but it's able to provide a high rate of flow, which in two ways really helps our patients. Number one, it obviously delivers the oxygen that they so desperately need. But number two, that rate of flow can help relieve some of that perceived dyspnea that our patients are experiencing. And then thirdly, there is a suggestion that high rate of flow could lead to some degree of PEEP to help maintain that alveolar opening. It's really hard to estimate. There may be 2 or 3 centimeters of water that we're getting of PEEP. Maybe. I think that more often, if a patient is breathing with their mouth closed, you might have a more effective administration or reception of PEEP in the lower airway. And I would guarantee for all of you that have seen COVID patients, nobody's just doing, closed mouth breathing. Everybody's panting for their air. And so whether or not that is useful is yet to be seen or hard to truly identify at the alveolar level. But oftentimes, once we get to that point, we've, once you're maxed out on your high flow oxygen, then you'll determine, does my patient need intubation or can we limp along like this? And, in attempting to avoid intubation, we've allowed some of our patients to place a non-rebreather over their high flow nasal cannula, whether it be their OptiFlow or the Salter, in order to create a little bit more of a reservoir for the oxygen that's in front of their face. And that has waylaid some of the individuals from being intubated as they're kind of limping along at maximum high flows, as well as placing that non-rebreather over their face, specifically when they're doing activities like getting up and out of bed, working with physical therapy, or doing any movement with inside their room. The last point I want to bring is bring up is that the higher rate of flow that we use, the more aerosol generating these OptiFlows are. So once you get over 30 liters of flow, there's a suggestion that there may be more aerosol generation. And while most oftentimes that won't make a big difference in our patients that are in closed, door MICU rooms, it could make a difference depending on how your emergency department is set up, as some, county ERs have just curtains that are separating some of their rooms. And so just being conscientious of how we isolate our patients and separate them depending on the rate of oxygen flow is an important thing to keep in mind. I don't know if anybody else wants to add to that.